Welcome everyone to ISQua's North American Community of Practice webinar. This is our June webinar. So far we've been having monthly sessions, and this particular session is artificial intelligence in healthcare. My name is Ulfat Sheikh and I am a board member at ISQua. I'm also a pediatrician and professor at the University of California, Davis School of Medicine, and I am pleased to be the moderator for today's session. Our guest is Dr. David Bates, who I will introduce shortly. I see our attendees joining this call. We have an all-time high of 532 people who registered for today's webinar, and I see several of them, a large chunk of them, joining on now. So welcome to all of you. While people join the call, I'd like to remind you about the October conference, ISQua's 41st International Conference from 12th to 15th October in Sao Paulo, Brazil. I look forward to meeting several of you in person there and chatting with you some more. We will try to get together an ISQua North America Community of Practice in-person group a meeting there. So again, looking forward to connecting with you all in person. And then in 2026, we will be in Dublin for ISQua's conference. And that is especially exciting because Dublin is the headquarters of ISQua. So it would be great to see you in ISQua's hometown there. In 2027, we will be in North America and Vancouver, Canada. So again, hopefully we'll see a large, growing, thriving community of the North America Community of Practice in person there. This is some information about how to join our community of practice. Registration is free as an ISQua guest if you're not an ISQua member. You have access to a community dashboard, you have some access to ISQua's resources, and you will receive updates on our monthly meetings. If you are an ISQua member, you will have access to all of ISQua's resources and also have a subscription to the International Journal for Quality in Healthcare and its various specialist certificates and the fellowship program. So lots of benefits. I've been an ISQua member for like 13 years now and find it really valuable for my own learning and getting to know improvers around the globe. If you have questions, comments, please place your questions in the Q&A section. I will be scanning that regularly and will be compiling questions for Dr. Bates to take at the end of his session. And without further ado, let's welcome you to today's session, Artificial Intelligence in Healthcare, presented by Dr. David Bates. Dr. Bates served for 25 years as the Chief of the Division of General Internal Medicine and Primary Care at Brigham and Women's Hospital and is currently the Medical Director of Clinical and Quality Analysis Information Systems at Mass General Brigham. He's a professor of medicine at Harvard Medical School and professor of health policy and management at the Harvard T.H. Chan School of Public Health, where he is the co-director of the program in clinical effectiveness. He's a member of the National Academy of Medicine and edits the Journal of Patient Safety. Dr. Bates is an internationally recognized and respected expert in the field of patient safety, and his primary informatics focus is around the use of information technology to measure and improve the quality of care within the field of medication safety. He's completed extensive research evaluating the incidence and prevention of adverse drug events and clinical decision support, and of course his other areas of research interest are around using AI to improve care, evaluating the impact of patient computing applications, provider satisfaction through electronic communications, health equity and improving quality of care and cost effectiveness of electronic communications and outcomes in those areas. So welcome, Dr. Bates. We are looking forward to learning from you today. And just a reminder to attendees, if you could put questions in the Q&A section, I will get those together for Dr. Bates to answer at the end of this talk.
Thanks so much, Dr. Sheikh. Can you see my screen?
Yes, I can.
Great. Well, it's a great pleasure to have the opportunity to be with you today, and it's really been fun just seeing where everybody is who's attending today. I'll be talking today about artificial intelligence in healthcare, and I'm looking forward to doing this. Okay. I have several disclosures. I work with a number of companies that make artificial intelligence. I'm not going to talk about any of them today. So I'm going to start by giving you some definitions, and then I'll give you some specific examples, talk about primary care use cases, talk about patient safety, then spend a few words telling you about cables, which is a center that we've developed here at Mass General Brigham, and then I will wrap up. So what is artificial intelligence? Well, it refers to the simulation of human intelligence in machines that are programmed to think like humans and mimic their actions. And the term can also be applied to any machine that exhibits traits associated with the human mind, like learning and problem solving. Now, this term has been around for a while, and there have been a number of hype cycles about this, but I think we're finally at the point where AI is becoming part of our everyday lives, and in which it's going to change healthcare profoundly. Here are a few definitions from an Annals paper that we published. I mentioned the first one already. Deep learning is a subset of machine learning that generally uses neural networks. Machine learning involves using algorithms and models which machines can use to learn without explicit instructions. And that learning can either be unsupervised, in which the machine learning goes ahead without direction from a human, or it can be supervised, in which the learning is based on input-output pairs. And a particularly important subset of this is deep learning, which was actually only accepted widely as being viable in 2012. And the way that this works is that you have digitized inputs like image or speech that go through multiple layers of neurons that progressively detect features and turn it into output. And usually in a model like this, you have between 5 and 1,000 hidden layers. And this is the technology that's been better than humans in Go and Texas Hold'em, among other games like chess. This is the main technology that's used in self-driving cars. And that you have to be able, when you're building a self-driving car, to tell the difference, for example, between a cat and a small child. And it takes a lot of work and investment to be able to do that. Deep learning models are often not validated in the real world. And the biggest issue is lack of annotated data sets. So in other words, data sets in which someone has gone through and said what this thing is and that thing is, and so on. Together with Christina Silcox of Duke and Susan Denser, we built this AI-enabled trust and value checklist for clinicians. So a few overarching issues. If you're using AI, you should be able to ask, does the use of this AI-enabled CDS software yield clinically important improvement compared to the status quo? A second, does the software fit into my clinical workflow or my team's workflow? That's absolutely pivotal. Next is, what information does the AI-enabled software provide at the point of use about the logic behind the decisions or recommendations that it produces, and the degree of certainty that the recommendations are correct. That degree of certainty often varies quite a bit, but most AI models don't tell you what the confidence intervals are. Also important are the data behind the decision support system. So what was the source of the data used to develop and train the software? And how were the training data labeled? In addition, does the AI-enabled CDS software appropriately respect patient privacy? Also important are how it was tested. So does the AI-enabled CDS software follow in the US under the Food and Drug Administration's regulatory authority? And if so, has it been cleared or approved by the agency? Turns out that most of the AI-enabled software that is used actually has not been approved by our regulatory authorities. And that's true, I think, in other countries too. And if a software system is not under that regulatory authority, how is it tested, against what standard, and by whom? And very importantly, has the AI-enabled software been tested on data from my own hospital or health system? So do you know it's really working well here? And then finally, and this is still being worked out, how is the software maintained and improved over time? And what provisions has the developer made for monitoring and updating that AI-enabled software to account for potential degradation in performance? The performance of this software typically goes down serially over time. And if you don't monitor that and track it, you'll not get the performance that you want. Okay, so what are the best use cases for AI in healthcare? Well, this is a really a great article by Eric Topol in Nature Medicine, and he suggested that the very best area is things that involve pattern recognition using deep neural networks. So looking at images, things like scans, pathology slides, skin lesions, retinal images, electrocardiograms, endoscopy, and vital signs. All of that works really very well. And usually what you do to assess it is compare physician assessment and look at true positive versus false positive rates with receiver operating characteristic curves, and the area under the curve used to express accuracy. And I'll give you some examples about this in a second. But here the main areas are clinically radiology, dermatology, pathology, ophthalmology, and cardiology, with emerging areas being gastroenterology and mental health. And these tools can also be used to help health systems make better choices or in other ways. So here's an example for chest radiographs. Sorry about that. Detection of pneumonia for 112,000 images was compared with radiologists. And in this instance, the algorithm outperformed the radiologist, but the area under the curve was just 0.76, with 1 being perfect and 0.76 being not very good. Now, a Google team used the same image set for 14 diagnoses, and they found that the area under the curve ranged quite a bit between diagnoses, which is typical. So it was 0.63 for pneumonia, which is clinically a relatively hard thing to determine, to 0.87 for heart enlargement or collapsed lung, which are easier to agree about. Notably, these algorithms are typically much, much faster than humans, up to 150 times faster than humans. But in nearly all instances in this area, the human plus the algorithm does best, and I'll come back to that. Here's an example from dermatology. So in one study, they looked at 130,000 photographic and dermoscopic images and compared 21 board-certified dermatologists to an algorithm. And the algorithm had an area under the curve of 0.96 for carcinoma, which is outstanding, and 0.94 for melanoma, and that's as good as dermatologists. Another study looked at accuracy of melanoma diagnosis by 58 dermatologists compared to a normal neural network. The dermatologists had an area of 0.79, whereas the algorithm had an area under the curve of 0.86. So that's significantly better for the algorithm in that case. Another study looked at an algorithmic assessment of 12 skin diseases, including basal cell carcinoma, squamous cell, and melanoma, compared with 16 dermatologists. And the algorithm area under the curve was 0.96. None of these was carried out in a clinical setting, but clearly this is this is something that has potential for clinical improvement. And, my expectation is that this will be expanded to other areas, like pathology, for example. Now, I'm going to spend a few minutes talking about primary care because I think this is a very interesting use case. And I'll start with a little bit of backdrop. Um, uh, in the US, we have nearly universal use of electronic health records by primary care providers, but that's had some side effects. If you spend too much time on the electronic health record, it's associated with emotional exhaustion. And PCPs who spend the most after hours time on the EHR have higher odds of emotional exhaustion. And spending over 90 minutes a day on the EHR outside the workday, or more than an hour of self-reported clerical work per day were associated with burnout. And among 40,000 family physicians, if you spent less time on the electronic health record, you were less likely to get burned out, about 40% less likely. And amongst family physicians in the United States, 4 in 10 report burnout. So that's a really high rate. And 40% of physicians have said that they're definitely are likely going to cut back in their clinical hours in the next 12 months. And a quarter of physicians said that they would definitely are likely leave their practice in the next 24 months, which those are really high figures. So, what can make a difference here? Well, virtual scribes have been quite effective. A virtual scribe is a situation in which you have someone who is not physically present in the room, basically develop the note. Here's one study which looked at 144 unique physicians who used a virtual scribe for at least 3 months. Nearly 2/3 were female, more than half were in primary care. Use of a virtual scribe was associated with substantial decreases in total electronic health record time per appointment, and scribe use was also associated with significant decreases in note time per appointment and pajama time per appointment. Pajama time is time at night that clinicians spend doing notes. And in a multivariable linear regression model, a number of factors were associated with significant decreases in total EHR time with a scribe use at 3 months, specifically practicing in a medical specialty, greater baseline electronic health record time per appointment, and decrease in the percentage of the note contributed by the physician. Now, all of this has led to just an incredible explosion of development of new companies that are using AI to do documentation. And this slide is just intended to illustrate kind of how many different companies there are in this space, but they cover several different areas. So some companies are focusing on ambient observation and monitoring. Some are focused on ambient clinical intelligence. I'm going to spend most of the time talking about ambient documentation, in which the AI is recording what's going on in the room and then using that information to develop a note. Ambient assistance is another area, and assessment of ambient experience is yet another domain that has lots of companies in it. So how does this actually work? Well, it's made a big difference. And AI scribes, in a study that was just done both here and at Emory University, was associated with a roughly 20% drop in burnout and a substantial increase in physician well-being and an ease of documentation. So clinicians really like using this, and they have found it to be really a kind of a game changer. So overall, to summarize, physicians are really positive about it. Patients are also happy with the results because you finish a visit and you actually have the note in hand and can show it to the patient. Physicians have reported reduction in burnout, and this is being rolled out rapidly in multiple institutions, and I think it's a technology that we'll see a lot more of. There are lots of other ways that AI could be used to change the way that we do clinician work. And this is a paper that I did together with Dr. Urmimala Sarkar from University of California, San Francisco. So we suggested that it could do things like prioritize patient messages, generate draft responses. We actually tried this here, and it didn't work out as well as we hoped. Physicians were not particularly happy with the draft responses, but I think it's a matter of time and iteration to get the AI to do a better job with that. It could also edit physician messages to optimize communication, including addressing literacy. Documentation can also be helped. I talked about that. So it can not only draft the progress note, but it could draft things like prior authorization, disability, and durable medical equipment results for clinicians, or draft a list of billing codes for visits. It can help a great deal with between visit panel management. So clinicians often are focused most on the patients who are coming to see them, but this would let us, for example, accurately identify patients who say need cancer screening using both structured and unstructured electronic health record data, find patients with incomplete cancer screening, and generate tailored messages to patients related to needed between visit care needs. In addition, it could help with individualized decision support, for example, help by identifying relevant information in both structured and unstructured electronic health record data to prioritize differential diagnoses for new systems. In Topol's Nature Medicine paper, he suggested that where we're eventually going in this space is that there'll be a variety of inputs. So things like social and behavioral data, and genomic and biosensor data from the immune system, all the patient's labs, family history, communication, their medical history, as well as the world's medical literature, all put together to make the right recommendations for an individual patient. And that, it seems to me, could truly transform the way that we're doing things and get us all the way to personalized medicine, which has been an elusive goal. Okay, well, this is an ISQua audience, and one of the main areas that I'm interested in is patient safety. So now I'm going to change gears a little bit and talk about what AI can do to improve patient safety. These are the main types of harm in hospitals: infections, adverse drug events, DVTs and PEs, surgical injuries, pressure ulcers, and falls, with new types of harm being decompensation and misdiagnoses. And I'm going to go through how well I think AI will do in helping us do better in these areas. And these come from a paper that we published, which is cited below. So let's start with hospital-acquired infections, which have been a big problem for a long time. This is an area which we've already had a pretty big improvement, especially for specific types of infections like catheter-related bloodstream infections, ventilator-associated pneumonia, and catheter-associated UTI. But there's a lot of variation in terms of how well these things are implemented by institution and even within institutions. And some of the opportunities for improvement with AI include in detection of hospital-acquired infections and for prevention in many areas. And a few of the key use cases, we think, are early identification of patients who have infections, including but not limited to sepsis, and also in assistance with triage decisions in infected patients, where to put them and how aggressively to treat them. and in linkage between isolates from multiple patients. Adverse drug events are an area that I personally have been very interested in for a long time. They cause a great deal of harm. They're the leading cause of harm in the hospital. They can either be preventable or associated with a medication error or not preventable. And here, we've had a good bit of improvement recently. At least in developed countries, mainly we've seen reduced rates of prescribing errors and administration errors. But some of the opportunities of improvement include that much of the currently implemented clinical decision support doesn't yet work that well. It could work better. And some of the key use cases include which patients may experience adverse drug events, leveraging things like genetic and genomic data. Often, for example, if you have a specific polymorphism, that is strongly predictive of having a problem. And also the whole summary of clinical information. And also which patients should have some specific testing, for example, for certain polymorphisms, or which patients should get specific prophylaxis if they're at risk of an adverse event. Thromboembolic events are also a big issue, deep venous thromboses and pulmonary emboli. And in this space, we've had a lot of improvement. There's robust evidence about which preventive strategies work, but they aren't always implemented as well as they should be. So opportunities for improvement include doing better with implementing preventive strategies for everyone. And some of the key use cases for AI include evaluating the thromboembolic risk in cancer patients. That's often been a tricky thing. It's clear that they're at elevated risk, but who should you anticoagulate? Which patients might get the most benefit from specific prophylaxis? And which patients with thromboembolism should undergo diagnostic testing, which can be costly and challenging. Pressure ulcers are also a really important safety issue. And these still occur way too often. Some strategies have documented benefit, but there are a lot of remaining opportunities for improvement. So for example, better sensing, especially for fluid, and when a patient is or is not moving, and leveraging some of the data that comes out of hospital beds in developed countries. Key use cases for AI include identifying which patients are at imminent risk using both clinical data and sensing, and determining which patients may benefit the most from expensive interventions, some of which are available in this area. Falls continue to be a really critical cause of harm. And overall, strategies like fall tips have been shown to be effective in randomized trials, but they're still not implemented in most organizations. I'll note that the fall tips information is available on the fall tips website. Implementation of fall tips was associated with a 25% decrease in falls in the main study, which was led by Dr. Patty Dykes, who's in our safety group. And some of the opportunities for improvement include reduction of the rates of falls, implementation of prevention strategies for high-risk groups, improvement of risk stratification, especially involve linkage with real-time monitoring, especially from sensors, and the use in new settings like long-term care and post-discharge patients who are at high risk. Decompensation is also a really critical area. Patients often decompensate in the hospital, and there's increasingly good evidence that if you get to them sooner, they'll do better from the outcomes perspective. So overall here, there's been some improvement, for example, with rapid response teams, but they have not been too effective, especially outside of intensive care units. And specific opportunities for improvement include better detection and earlier detection of decompensation overall, and for specific reasons like sepsis or bleeding. Some of the key use cases here include, as I mentioned, early identification of decompensation overall, but also sepsis, early identification of post-op bleeding, and then decompensation in a variety of settings, most specifically post-discharge, which has been a challenge for most organizations. Some of the best work in this space has been done by this group from Kaiser, which was led by Gabriel Escobar and Vinnie Liu. And they built an algorithm which lets them, across many hospitals at Kaiser, identify adults at risk for in-hospital deterioration. And this is just a table from their New England Journal paper, which shows that the mortality rate fell by 16% after putting this in place. Sepsis is an extremely important area. This remains one of the leading causes of death worldwide. And a number of organizations have developed good tools in this area. For example, Hospital Corporation of America, or HCA, has developed a real-time tool called SPOT, which they validated on about 2.5 million patients, and they estimate that they've saved 8,000 lives over a 5-year period. Duke has rolled out a system called Sepsis Watch, which was trained on 50,000 patients and has 32 million data points. And there are lots of organizations working in this area worldwide for obvious reasons. But using an algorithm doesn't necessarily turn out the way that you want. This is a study that was done evaluating the EPIC sepsis model, and they looked at 27,000 patients who had 38,000 hospitalizations. Sepsis occurred in 7% of the operations, but the EPIC sepsis model predicted the onset of sepsis with an area under the curve of only 0.63, which is quite poor performance, and it's substantially worse than the performance that had been reported by its developer. EPIC had reported that the area under the curve was 76 to 83%. And furthermore, what happened here was that there were alerts in lots of patients who didn't have sepsis. So 1 in 5 patients had a sepsis alert, and of them, only 12% had sepsis. That had predictably very negative effects on the frontline providers who were tired of responding to all these alarms. And yet this model is widely implemented. It turned out that what EPIC had done was they developed the model in only 3 institutions and then assumed it would work the same way in many other institutions, and that is not necessarily the case. The performance of a model like this typically declines quite a bit when you take it to new places, and so this underscores a point that I made early on. If you're going to use a tool like this, you absolutely have to test it in your own institution and see how well it's performing, and you can expect its performance to get worse over time. Missed and delayed diagnoses are also a really important area from the safety perspective. This is a big opportunity, I think, for artificial intelligence. It appears to represent a really big problem, especially in the outpatient setting. In the inpatient setting, this is less clear. There's a National Academy report on this topic. But there are lots of opportunities for improvement. For example, making specific diagnoses sooner and more accurately, like pulmonary embolism. There's also really big opportunity for reducing delays in diagnosis, especially for common malignancies like lung, colon, breast, and prostate cancer. And some of the key use cases include identifying clinical situations in which a diagnosis may have been missed, and identifying scenarios in which there's been a delay longer than expected, an acceptable alternative. Hardeep Singh has done some of the best work on this in the outpatient setting, and has showed that delays in diagnosis, especially in the outpatient setting, are very frequent, and they're preventable. So a few limitations here. There are many other causes of harm that I didn't talk about, but the ones that I went through are the biggest ones. And that uses the Pareto principle, which suggests that if you deal with the biggest causes, you'll get a lot of the possible improvement. There's been a lot more focus on safety in the inpatient setting than in other settings, and in the outpatient setting especially deserves more attention. There are many areas that have not been considered safety issues, like decompensation, that are on the borderline, but I think it makes sense to consider them safety issues because there's such big opportunity to improve care and save lives. I also believe it's going to be extremely important to have better measurement of inpatient and outpatient safety routinely, and that is now possible with if electronic health records in place. You can go through the record and look for signals that the patient might have suffered harm. And in addition, I think patient engagement will play a big role. We recently did a study that involves showing patients their own risk for safety events, and they really liked seeing that data. And I think that can be expected to reduce the risk. So what do you have to do to actually get benefit from AI and machine learning? Making good predictions is actually not you pick the best one. And I would say it's more important to use a model versus which particular one you used. In addition, picking good use cases is critical. The use cases need to match your clinical need. It might be which therapy to pick versus identifying a diagnosis. You want to have a gap between performance and the ideal. The very most important thing is getting suggestions to the right clinician at the right time. And in developed countries, clinicians typically are overwhelmed with suggestions, and the last thing that they want is more. And you have to have an ability to find the right clinician, which is a tricky thing. You often need to do this in real time. And how you deliver the suggestions is also extremely important. The behavioral economics techniques show that if you make the right thing to do, the easy thing to do, people will be much more likely to do it. So for example, if you're suggesting a vaccination and you're pretty sure the vaccination should be given, your default for giving the vaccination should be give the vaccination as opposed to don't do it. It's also really important how this is integrated with clinical care. And as I mentioned earlier, Kaiser has done some of the best work in clinical care. They've focused in particular, on estimating the risk of complications at, for example, admission, evaluation, or triage. If you're going to do this, you need a detailed guideline that clarifies how the algorithm will inform care. So it says, okay, if the patient's in this particular area, then you should admit them to a step-down unit, that kind of thing. Some examples that they've put in place that worked very well include evaluating newborns for early onset sepsis and using emergency department composite scores to predict decompensation. And you have to get the information to the right person in the unit in a very timely way. Now I want to tell you just briefly about a center that we put in place at Mass General Brigham across our network that I'm co-leading together with Dr. Sean Murphy. The cable's mission is to provide educational developmental resources and consultative expertise to help improve patient care in a learning healthcare system. And a learning healthcare system is a healthcare system in which internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice. And many organizations have wanted to use these terms, but it's hard to actually deliver. cables, we believe, fills an important need for Mass General Brigham. So, the idea is we want to be a learning healthcare system in which the knowledge that we gain through AI and biomedical informatics research is put into practice to improve patient care, efficiency, and work satisfaction. We're trying to develop faculty who are interested in this space. And currently, we have lots of people working in this area, but they're in many different groups, and they don't always know each other or work together well. So we're trying to enable people to come together. And we also plan to set up a division that will focus on this area. So several conclusions. I think artificial intelligence and machine learning are truly transformative technologies, and that medicine has been relatively late to the party, and we need to use it more broadly. There are many use cases for this in healthcare. I've gone through many, and image evaluation is currently the farthest along. I will note again that human plus the machine almost always does best, and I think that will help a lot in the near term. I don't think that humans will be replaced anytime soon, although some areas which have been tricky, like having the AI predict what the diagnosis is, suggest that the AI is doing increasingly well. I think AI will enable major improvements in areas like safety. For many of the main types of harm, improvement will be incremental, but for some of the harm types that have gotten less attention, like decompensation, diagnostic error, radical or transformational improvement is possible. I think relatively simple machine learning will deliver a lot of the first benefits in healthcare. And with machine learning, external validation is critical, and it's often left out. There's a lot of hype in this space. There's a tension between explainability and performance. So sometimes you can't say exactly where the recommendations came from. I have not talked a lot about large language models in this talk, but much of the work that we're doing now does involve large language models, and they also will clearly be hugely important going forward for many things. And finally, I think that many of the improvements will involve leveraging multiple technologies like artificial intelligence and other big data techniques, sensing, communication, the Internet of Things, in which devices in a patient's home, for example, are linked to our clinical systems. And all of this should be linked to tracking of performance. And if you want to read something about these areas, here are a couple of really good articles. This first paper by Suchi Saria, Atul Butte, and Aziz Sheikh, and a second one by Eric Topol. And I will stop there and take some questions.
Great. Thank you so much, Dr. Bates. We have a few questions that I will compile for your consideration. There were a couple of attendees who requested specific info on the webinar, as well as some of the resources that were mentioned, which I've already sent them and also added to the chat. So one of the questions that came up, Dr. Bates, is you mentioned the potential for AI in mental health. And the attendee asked for if you had any more examples in psychiatry of the use of AI, apart from the Scribe software that you described.
Yeah, there's a huge range, and psychiatry is actually one of the areas that I think will be most affected. There was a very recent review that just came out by Eric Topol and John Torres from Harvard on the potential opportunities in this space, and there are really a huge range, and it will probably make a very big difference. For example, in interacting with and tracking patients when they're outside in the institutions in their homes. But that article is an authoritative one, and I would encourage people to take a look at that.
And there was another question about algorithms and the data they need to learn. And the question was specifically around how do you access this data that these AI are learning from? Do you consent patients to use this data for research, or specific consents around utilizing their data to develop AI solutions?
Yeah, that's a great question. The way that we handle that is we actually require everyone, if they want to get care at uh, our organization, to agree to allow their data to be used if it's de-identified. And what we do is accumulate all the data, but we have a very thoroughly de-identified version that we use to develop AI with. And increasingly, organizations are going to need resources like that they have, so that they can use to develop their own AI or test outside AI that has been developed by others.
Great, thank you so much. And just to acknowledge the folks that asked those questions, the mental health question was from Danushti Livera, and then the question about the algorithm is from Iman Ridwan. So moving on to the next question, I have a question from Pierre Barker, and the question is, apart from ambient listening, what are the opportunities for using AI in low and middle income settings that don't have electronic health records?
Yeah, so that's a really good question. I mean, I think it's not completely clear what the best opportunities are in that setting. I've been extremely impressed, though, that even very low tech tools can make a huge difference in low resource settings. And one of my favorite examples is some work that was done in Tanzania around the availability of antimalarials. The final intervention was just to actually have every health center in the country text in as to whether or not they had antimalarials on a given day. And after the central group had that information, they were able to make sure that antimalarials were essentially available everywhere all the time. They had enough antimalarials, but before doing that, roughly half the time, health centers were out of antimalarials. So in low resource settings, there's still ways to use tools like this. You just have to be creative about it. And I think we'll have to see how that develops going forward. But that's a very big opportunity. The way I would start there is start with the big problems like malaria and TB and some other things, and then work backwards as to what the needs are.
Thank you, Dr. Bates. There was a question from Haneen Omar, and this was about other applications of AI. So specifically, the question was around AI applications to analyze qualitative data sets, such as scripts from meetings. The person who asked the question was thinking about patient safety reviews, patient interviews, etc.
Yeah, there haven't been as many evaluations of doing that so far as I think that there should be, but the tools for doing that are increasingly robust, and it should be possible, for example, to take meetings like that and use large language models to go through and figure out what the key common threads are, and that can in turn be used to develop preventive solutions.
Great, thank you. And there is a somewhat related question from Bronwyn Lee Guerrer, and this isn't the qualitative content that the previous person was mentioning, but this question extends into finding things within EHR. So the specific question is, that Bronwyn can appreciate that a lot of the focus for AI in healthcare has been within the clinical setting. However, they're wondering about peripheral clinical opportunities, like easy ways to find terms and concepts within and summarize policy documents within EHRs when you need specific information quickly to make a decision or develop policies or summarize patient experience for better discharge education.
Yeah, so large language models are fantastic at doing that kind of task, and can be really helpful in generating um, very useful documents at a rate that just would not be possible without them. So yeah, so that there's a lot of opportunity there.
Great, thank you. And this next question is from Surya Teja Akela, and they mentioned that they're, I know what's, Dr. Bates, a lot of what you mentioned was around the clinical realm, but this person who asked this question is pursuing an MBA in hospital administration and healthcare management. So their question is, what AI trends can they learn in this field to help them with their work?
Sure, I think it can be extremely helpful in that area. So for example, you can use AI to predict what staffing you need, to optimize the use of a variety of scarce resources. And there's a kind of a whole nother area of operational use of AI to optimize our enterprises, which the most expensive thing in healthcare is first nursing time, but second physician time, and so doing a better job of staffing and evening things out, it it will be really helpful.
Great. And then there is a question from Ala Brudiman about wearables. So the question is specifically, could you touch on the integration of AI and wearable remote monitoring devices for patients in care facilities and those living independently, sometimes with support in the community?
Yeah, I think that's going to be just an area of explosive growth in the next few years. It's been estimated that it will be possible, for example, to measure as much as several hundred parameters at the same time within a few years from now, and that should enable us to do a much better job than we can today at predicting, who's going to have a problem or is having a problem. So I think that's just an area in which we're going to see tremendous growth. The glucose monitors are already a transformative technology for people with diabetes who are able to manage them. But we'll be seeing lots more in that space.
There's several more questions about clinical applications, but before we attend to those, let's just quickly take on this one question we have about suggesting any healthcare AI training modules for quality professionals. And before I let David give his suggestions, I am aware, Dr. Bates, you can add to that, ISQua is developing or has already on board as part of his fellowship program, right? AI training, but perhaps you could expand on that. But ISQua has several resources, and I know Dr. Bates has other suggestions as well.
Yeah, I think that there's an opportunity to do a lot in that space. My guess is that a large part of healthcare education will be done using AI in the not too distant future. That you might say, spend half your time uh, with AI, and then the other half in doing other things in terms of of learning about a particular space or how to manage things. So AI is going to be highly relevant in this area.
I'm going to combine a couple of questions because they touch on similar aspects and they all have to do with things we need to be watching out for, right? Like now there is enthusiasm around use of AI technologies, but some of, I guess, the balancing measures here. So the specific questions are the two questions that I can combine as the patient safety vulnerabilities with implementation of emerging AI, and then Isha Ray Chaudhary asks, the benefits in safety for AI are well recognized, but its role in decision making for seriously ill people remains unclear. There are issues around trust, value, and to what extent are providers made aware of the limitations of AI in different settings?
Yeah, well, the thing I'm most concerned about with AI is that it could worsen disparities in care, and there's already evidence that that has happened if you're not really careful. So that's one area I would say to pay a lot of attention to and to watch um, uh, very closely. Um, and any technology like this, especially one that's this transformative, does have potential downsides and risks, and I think we need to be um, uh, watching those and tallying them up and looking to see where the problems occur as they will inevitably. At the same time, for many things, this is just, much faster and it's better. There's a big mammographic study that was in, I think, Denmark, someplace in the EU. The technology read mammograms with very high accuracy rates and was about 10 times as fast as having humans read them. That's a place where I think we'll just be going to having the AI read most of the algorithms, and then just have the humans focus on the difficult ones.
All right, we have a couple of minutes more, and I'm trying to prioritize the questions we still have here. But Kiran Kumar Sarai asks, are there any openware healthcare AI tools available to explore?
Yeah, there's a big range, for example, of large language models. So the ones that you might hear the most about, like ChatGPT, is quite expensive, but there are increasingly smaller free AI tools that are available that perform really well, particularly in specific contexts. And I think one of the big frontiers in this space will be going through and finding one of those less expensive or even free tools as good as the more expensive, more complicated ones.
Great. And to wrap up this webinar, let me ask you one last question. And this is from Lisa Hirschhorn. Aside from image interpretation, which is underway, what is the progress and opportunity for improving gaps from evidence to practice using AI? So some of the questions that Lisa posed are in the area of neonatal sepsis or the diagnosis for geriatric syndromes as examples.
Yeah, I think both of those are places where there's big opportunity for improvement. Neonatal sepsis is one that this works really, really well for. It's a very difficult diagnosis to make. It can be really subtle. Um, and AI, performs very well. What was the other one that you mentioned? It was
Uh,
geriatric syndromes?
yeah, geriatrics, yeah,
Yeah,
neonatal.
and it's very good at that too, although the evidence is not as far along, I would say, as for example, with neonatal sepsis, where it's pretty robust.
Great. Thank you
Great
so
set
much,
of
Dr.
questions. Yeah.
Yeah. All right. Well, because we are at the top of the hour, I'm going to wrap up today's session. Dr. Bates, I thank you for your time and for the amazing learning we had today. For those of you on the call that will be at the October Sao Paulo conference that ISQua has, our annual conference, just a plug for a joint session that Dr. Bates and I and Fabio Gastal from Brazil and Aziz Sheikh from the UK will be teaching together in Sao Paulo. It's called High Tech and High Touch, using technology to support primary care. So hope to see several of you in person at that session. And just a note that in July we have a hiatus from these webinars for the summer, but we'll resume these webinars back in August with an amazing lineup of guests. So hope to see you all there. Thank you, Dr. Bates, for your time, and for the rest of you, have an amazing rest of the day. Bye.
Thanks for having me.